Hypertension. Secondary cause of hypertension is chronic kidney disease, anemia, low GFR, small kidneys, renovascular hypertension, abdominal bruit, elevated plasma renin activity, increased 30% elevation of creatinine with starting BP lowering agents, hypothyroidism, parathyroidism, elevated calcium, phenochromolithic tumor, a tumor on the adrenal gland, sleep apnea, primary aldosteronism, hypokalemia, ratio serum aldosterone plasma renin activity greater than 25 to 30. Medications that can cause hypertension, oral contraceptives, hormonals, nicotine, vasoconstriction, steroids, appetite suppressants, tricycline, antidepressants, and antidepressants, venlafaxine, Effexor, cyclosporin, Sandomun, nasal decongestants, non-steroidal anti-inflammatory drugs, and NSAIDs because it reduces the sodium excretion. We're going to follow the different guidelines. We have the GNC 8, normal blood pressure less than 120/80, pre-hypertension 120 to 139, systolic, diastolic 80 to 89. Stage 1 hypertension is 140 to 159 systolic, 90 to 99 diastolic. Stage 2 is greater or equal to 160/100. The ACC-AHA, normal blood pressure is 120 to 80. Elevated blood pressure is 120, 129 systolic, and less than 80 diastolic. Stage 1 is 130 to 139 or 80 to 89. Stage 2, greater than 140 and greater than 90. Once again, for treatment, the GNC 8, blood pressure greater than 140/90 is to initiate pharmacological therapy. If ages less than 60 and have chronic kidney disease or diabetes. BP 150/90, initiate therapy for patients that are over 60 with no kidney disease or diabetes. Once again, you will only treat blood pressure 140/90 unless they have chronic kidney disease, diabetes, and they are under the age of 60. You treat 150/90 if they are over 60 with no chronic kidney disease or diabetes. ACC-AHA, once again, normal blood pressure is less than 120/80. Elevated blood pressure, you would do a trial of non-pharmacological therapies, lifestyle changes. Stage 1, you do a trial of non-pharmacological therapies if the ASCVD risk, atherosclerosis cardiovascular disease risk, is less than 10%. If unsuccessful, add pharmacological therapy. Non-pharmacological therapy and pharmacological therapy if ASCVD risk is over 10% or clinical ASCVD. Once again, stage 1, you do trial if they have a low risk. If unsuccessful, you add pharmacological treatment. For greater risk, you do non-pharmacological treatment and pharmacological treatment. Or they have clinical atherosclerosis cardiovascular disease. Stage 2 hypertension, you initiate pharmacological and non-pharmacological therapy. Can initiate 2 medications if BP is greater than 20/10 mmHg over the goal. ASCVD criteria is age, race, sex, total cholesterol, statin use, smoker, diabetes mellitus, aspirin use, hypertension, and systolic blood pressure. JNC8 goals are for people age 60 and below, with chronic kidney disease or diabetes. We want to maintain 140/90. If over age 60 with no chronic kidney disease or diabetes, 150/90. Lower blood pressure is okay if well tolerated. ACC-AHA goal is 10 years atherosclerosis cardiovascular disease risk greater or equal to 10% for a blood pressure of 130/80. Lower than 10-year atherosclerosis cardiovascular disease risk goal is 130/80, may also be reasonable. Formula factors, once again, age, race, gender, total cholesterol, meaning HDL, LDL, history of statin use, systolic blood pressures, treatment for hypertension, history of diabetes, and current smoking and aspirin use. Drug therapy to manage hypertension. We reduce the cardiovascular disease by including lipid disorders, glucose intolerance or diabetes, obesity, smoking, and renal disease. Hypertension lines of therapy. First is thiazides, calcium channel blockers, ARBs, and ACEs. 2, it's going to be a thiazide plus a calcium channel blocker for African Americans. First line treatment, thiazide diuretics, calcium channel blockers, ACE inhibitors, ARBs. For African American patients, it's thiazides and calcium channel blockers. For patients with stage 2 hypertension, initiation of 2 agents from different classes is recommended. In patients with diabetes or chronic kidney disease, an ACE inhibitor or ARB should be prescribed regardless of race, with the goal of preserving renal function. Thiazide diuretics. Action is to decrease the blood pressure by inhibiting the reabsorption of sodium and chloride in the distal tubules, resulting in increased secretion of sodium and chloride. Members of this class is hydrochlorothiazide and chlorothalidone. Adverse reactions that are rare, serious, and important. Gout. Thiazide diuretics can have gout and hypercalcemia, hypochloremia, alkalosis, acute transient myopia, and acute angle closure glaucoma may precipitate digitalis, inducing arrhythmias in patients taking digoxin. Patient education. Take in the morning, avoid nocturia. Maximum therapeutic benefit takes several days. The beta blockers are the ones that end with OLOL. Their action is competitive blockade of response to the beta adrenergic stimulation at the receptor level, resulting in decreased heart rate, myocardial contractility, blood pressure, and myocardial oxygen demand. Beta 1 is selective agents, selective beta blocker 1 receptors with little to no effect on beta 2 receptors. Non-selective agents antagonize both types of receptors. Members of this class are atenolol, which is a beta 1 selector, used cautiously in elderly patients with renal dysfunction due to the significant increase in half-life risk of toxicity. Metoprolol tartrate, low pressure, is beta 1 selective. Extended release version toprol XL, propanolol, Inderal LA. They are non-selective, frequent choice for treatment for performance anxiety and migraine prophylaxis. ACE inhibitors is the prils. Action is the suppression of the renin angiotensin aldosterone system. Inhibits the conversion of the angiotensin 1 to angiotensin 2, reducing the vasoconstriction and release of aldosterone. The latter reduces the retention of sodium and water. Common adverse reaction is hypotension, hyperkalemia, cough, taste disorders, captopril. Rare but severe and important reaction, angioedema, renal failure, azotemia. Major drug interactions, additives to hypotensive effect when used with other antihypertensive drugs. Hyperkalemia risk when used with potassium-sparing diuretics, TMP, SMX, or ARBs. Do not use ACE inhibitors and ARBs concurrently. NSAIDs reduce the hypotensive effect of ACE inhibitors. Monitoring serum creatinine, potassium, cough symptoms, angioedema, and blood pressure. Educate patients on signs and symptoms of angioedema. Monitor labs, avoidance of potassium-based salt substitutes, discontinuation with pregnancy. Members of this class: benzapril, captopril, lisinopril. ARBs, or the sartans. Action also works on the renin angiotensin aldosterone system by blocking the binding of the angiotensin to angiotensin 1, reducing the angiotensin 2 effect. This blocks the receptor. ACE inhibitors prevent the conversion. ARBs block the receptor. Angiotensin 2 is a potent vasoconstrictor and promotes release of aldosterone, resulting in sodium and water retention. Do not cause cough, considered a major advantage. Pregnancy category D. This class is positive for evidence of fetal risk. Members of the class are losartan, valsartan, candesartan, ibisartan, telmisartan. Then we have calcium channel blockers. Just to note, antifungals can increase the hypotensive effects. And there are two types of calcium channel blockers. There is the dihydrofuorides and the non-dihydrofuorides. The non-dihydrofuorides, remember by diver. So verapamil and deltazon. So the DI and in the deltazosam and the VER and the verapamil. The dihydropamines are all ending with PINE, so the pines. Benzothiazepines, diltiazem is the only member of this class. It is used for the treatment of hypertension and control of heart rate in patients with arterial fibrillation, the effects on the BP and cardiac condition. Inhibits the movement of calcium ions across the cell membrane, resulting in vasodilation and depression and impulse formation and conduction of the velocity of the AV node. Rare and severe important side effects is third-degree AV block, worsening heart failure, dermatologic reaction including the Stevens-Johnson syndrome, gingival hyperplasia, drugs that affect diltiazem is the CYP3A4 inhibitors, cyclosporins, HMG-CoA reductase inhibitors, increase the concentration, the sartans, or statins, not sartans, statins, used for cholesterol. Effects. Azole antifungal agents increase the hypotension effect. Erythromycin decrease metabolism. Rifampin decreases the hypotension effect. And it decreases the metabolism of phenytonin. Patients' education: take on an empty stomach and do not crush long-acting drugs. The dihydropyridines, they inhibit the movement of the calcium ion across the cell membrane, resulting in relaxation of the vascular smooth muscle and the coronary and peripheral vascular arterial vasodilation, reducing peripheral vascular resistance and blood pressure. Common adverse reaction is hypotension and peripheral edema. Rare but severe important adverse reaction is postural hypertension or hypotension. Members of this class is amlodipine, felodipine, and nifedipine. Immediate release formulas of the nifedipine is not recommended for use due to reported serious events including death, cardiovascular ischemia, syncope, stroke, acute MI. Next medication is the phenethylamines. This is also a non-drug. Verapamil is the only member of this class. It inhibits the movement of calcium ions across the cell membrane, resulting in vasodilation. Also depresses impulses, formations, and conduction velocity in the AV node. So used for treatment of hypertension and heart rate control in patients with AFib. Pregnancy category C. Common side effect is bradycardia, constipation, gingival hyperplasia, hypotension, and peripheral edema. Important rare side effects: worsening heart failure, hepatic injury, increased enzymes, drugs affecting verapamil, amiodarone, a beta blocker, increased risk of bradycardia. Erythromycin, increased levels. Fluconazole, increased effects. Verapamil, effect on other drugs, increased digoxin levels. Decreases metabolism of phenytonin, increases the lopatine levels, increased levels of risk for toxicity in lovastatin, Simivat. The statins educate patients, do not crush extended release, and once again, use of prescriptions. You have a BP of 120 to 139 over 80, 89. Lifestyle modifications is recommended. Consider initiation of drug therapy. If the patient is under 60 years old and has a blood pressure over 140 over 90, non-African American, thiazide diuretic, or a ARB or ACE alone, or in combo. If the patient is African American, thiazide type diuretic or calcium channel blocker, all races with diabetes and chronic kidney disease. An ACE or ARB or combo with other. That is, you treat for somebody under the age of 60 with blood pressure over 140/90, or over 60 with a blood pressure over 150/90. Max out one drug before you switch to a second drug. Hyperlipidemia, the HMG CoA reductase inhibitors, the statins. They primarily block the conversion of the HMG-CoA to mevalonate, which is a rate-limiting step. It blocks the enzyme, increasing the cholesterol in the body. Treatment is recommended clinical ASCVD. You go with high intensity treatment if they're under 75, moderate intensity if they are greater or equal to 75 years. Second, no ASCVD, but LDL greater or equal to 190, high intensity unless contraindicated. 3, no ASCVD, but 40 to 75 years with diabetes mellitus and an LDL of 70 to 189, moderate treatment if less than 7.5. Increase intensity if over or equal to 7.5. 4, no ASCVD or diabetes under 40 to 75. ASCVD greater or equal to or greater than 75 or 7.5%. Do moderate intensity if greater or equal to 7.5. Here are the statin drugs, the atorvastatin and the rosuvastatin. They are the only two used for high intensity, but they are also used for moderate intensity. Simvastatin and lovastatin are used for moderate and low intensity. And pravastatin is also used for moderate and low. And fluvastatin is used for moderate and low. Pitavastatin is, on this one, used for moderate and low. Once again, the action is primarily blocking the conversion of the HMG-CoA enzyme, which is a rate-limiting step in the production of cholesterol in the liver. Maximum effect usually are seen after 4 to 6 weeks of therapy. For this reason, dosage adjustments should not be done prior to every 4 weeks. Contraindication, pregnancy and lactating women, active liver disease, unexplained aminotransferase levels, and heavy alcohol use. Most drugs in this class are substrates. Pravastatin is the exception. So this must be considered when prescribing statins for patients who are taking other medications that interact with the CYP 450 enzymes. Goal of the treatment is 50% or greater LDL-C reduction in high-intensity statins therapies. 30 to 49% reduction with moderate. Adverse events, well tolerated by most patients. GI complaints, headache may occur. Myopathies, leg tiredness, and rhabdomyolysis can occur. Drugs can also cause myopathy, cyclosporin, erythromycin, and antifungals. Be mindful of factors that can independently increase CK. Baseline measurements of CK is reasonable for strenuous activity and IM injections. Ongoing routine monitoring of alanine aminotrans ALT or creatine kinase CK is not recommended unless patient is symptomatic. Muscle symptoms. If patient complains of muscle symptoms, discontinue the statin until symptoms can be evaluated. Evaluate the patient for other factors that may be contributing: hypothyroidism, reduced renal, hepatic function, primary muscle disease, rheumatic disease. If the symptoms resolve and no contraindication, resume the same or lower dose. If symptoms reoccur, with resumption of the same statin, discontinue and use a low dose of a different statin. Rhabdomyolysis, unexplained severe muscle symptoms or fatigue developed during statin therapy. Immediate discontinuation of statin, CK, creatinine, and urinalysis for myoglobulinemia. There is no convincing evidence that routine use of non-statin lipid-lowering medications, i.e. Zetia, niacin fibrates, and omega-3 are useful as primary prevention of ASCVD. Alternate therapies, antioxidant therapies, garlic, vinegar, fish oils, combinations of lovastatin, niacin, simvastatin, niacin, so that is Advicor and Symbicor. Statins and niacins and statins and gemfibrozine are used in patients with severely elevated LDL cholesterol, low HDL cholesterol, and hypertriglyceridemia. Combination statins with cholesterol absorption inhibitors has shown added benefit to both reducing LDL cholesterol and the ASCVD event rates. Bile acid resins can be used safely and effectively with statins, niacins, and fibric acid derivatives to enhance LDL lowering. Bile acid resins actions decrease the cholesterol absorption through the extraneous pathways, can decrease LDL cholesterol levels by 15 to 30%, increase HDL levels by approximately 3%, and increase triglyceride levels by up to 15%. Contraindication is for fasting. Triglyceride levels of over or equal to 300. Adverse events, GI-related interactions should be taken with foods. First line is statin therapy. Second line is cholesterol absorption inhibitors, niacin, bile acid resins. Third line is the fibric acid derivatives. Chapter 21, Coronary Artery Disease. Goals of treatment is to relieve acute anginal episodes, preventing additional anginal episodes, preventing progressive CHD, reducing the risk of MI, improving functionality capacity, and prolonging the survival and maintaining patients' quality of life, avoiding adverse events associated with the therapy. Nitrates as the mechanism of action is treatment. It relaxes the vasculature of the smooth muscle, venous dilation with dose-dependent atrial effects. Nitrates are used for the treatment of angina that is stable and unstable. We have isorbidide and nitrostat, and they can cause bradycardia and headache and syncope and weakness. No ETOH, severe hypotension, not for the use of impotence. Increased hypotension, Viagra, and Cialis are used for impotence and have a similar effect. Avoid with use of Viagra and Cialis within 24 to 48 hours of each other, not to be used with a systolic of less than 90 or a diastolic of less than 50. Monitor BPH, headache, and heart rate. Headache means that the medication is working. It can be taken sublingually only for emergencies. We have additional medication lists here. We have the select recommended order of treatment for angina for all patients: short-acting nitrates, aspirin if not contraindicated, chronic prevention of angina, episodes of beta blocker. Second line is a calcium channel blocker and combination therapy.